Winston, you're now live on camera. If you could just unmute your microphone and prepare your slides, that'll be great.
All right, thank you. Can you hear me?
Yes,
Vicky?
we can hear you loud and clear, thank you. Perfect,
so let me get started. So hi everyone, real pleasure to be able to present to you through online like this evening. So I'm Winston Kim, I'm a hip and knee surgeon, and my talk this evening is focused on robot-assisted knee replacement. So I'm going to start with a brief chat on what knee arthritis is all about and ask the question, why robot-assisted knee replacement? I'll go through what it is, and I'm going to share with you some of the early outcomes of robot-assisted knee replacement and possibly ask you, possibly suggest that this may be a part of the future of knee replacement surgery. So what is osteoarthritis? It is very simply loss of the hard cartilage that caps the bottom bit of your thigh bone and the top of your shin bone. So it is a spectrum of disease, so you can have mild thinning of the cartilage right up to complete loss of that hard cartilage, is what you can see on your right. So that big cartilage, and that is apparent on the X-ray, as you can see on the bottom right there. You have bone-on-bone appearance because that patient has lost all the hard cartilage on the thigh bone and the shin bone side of his knee. And how arthritis progress is variable, and it's an interplay of various factors: genetics, your weight, work, whether you have previous history of trauma in the knee. It's important to know that knee arthritis is not just due to structural reasons. So it's not just loss of the hard cartilage that causes pain in your knee. Patients experience pain due to a combination of muscle weakness, scar tissue, and this is quite important to note, because when you recover from knee replacement, you may have question marks about whether the knee implant is functioning, but oftentimes it is often due to muscular and not structural factors. Knee replacement is not the only thing, the only method we have of managing knee arthritis. It's very important to know that strengthening exercises can make a significant difference, especially in the early stages of arthritis. I'm not a big fan of steroid injections, but it's an option in the management of mild to moderate arthritis. You can use your own blood. This is called platelet-rich plasma, and there's emerging evidence that this may be helpful or a useful adjunct in the management of patients with arthritis. Similarly, you have lubricant, also known as hyaluronic acid injections, that again may be a useful tool in the management of mild to moderate arthritis. But in patients who have severe arthritis, and the way you know is if you can see on the right, this is a repeat of the picture I've shown earlier, if you have bone-on-bone appearances, whether it's in the hip or the knee, you will probably have quite severe symptoms from end-stage arthritis of the knee or in the hip. Hip and knee replacements work. In England and Wales, over 100,000 hips and over 100,000 knee replacements are performed every year. So why robot-assisted knee replacement? Well, for a start, knee replacement is not minor surgery. Patients often complain that they take a long time to recover, and certainly when I do hip replacements, patients recover much quicker, and they seem to be a lot happier, much quicker. So, but the overall satisfaction from knee replacement is also much lower. The literature would report dissatisfaction rates of up to 20%. So 1 in 5 patients are not happy with your knee replacements. We're seeing increasingly younger patients who want to be able to return to high levels of activities, skiing, tennis, and you know, they have high expectations of what the knee replacement should achieve for them. There's this demand for a normal feeling or natural feeling knee. And the challenge for surgeons is that the knee replacement is a highly technical operation. It's easy to get it wrong, and it's hard to be consistent, especially if you want to do a partial knee replacement, such as what you can see in the bottom picture. We know that knee replacements are very sensitive to errors, and the converse is also true. So if we accurately and precisely position the knee replacement implant, we know patients do better. There are a lot of studies that have shown that if you get it wrong technically, that you will have a poor outcome, and is one of the reasons why patients are unhappy following knee replacement surgery. And it's this dissatisfaction and long recovery that is driving the various innovation in knee replacement surgery, from personalized implants to robot-assisted technology. The Mako robot arm-assisted knee replacement is a procedure that was launched in 2016. That's the total knee platform. The partial knee has been around since 2006. And what it does is it combines CT imaging, and this is multiple X-rays essentially, with 3D technology. And it allows the surgeon to construct a plan, a surgical plan, even before surgery. So what it means is enhanced planning even before the patient enters the surgical operating theater. During surgery, what happens is that sensors are placed around the joint, which allows the robot and the software to detect the joint. The robot then enters the surgical field and is able to make cuts that are very precise and accurate according to the surgical plan that the surgeon made before surgery. And these cuts are precise to fractions of millimeters. And what it also does, it allows the surgeon to fine-tune the operation. And what you see on the bottom left here is a virtual boundary. So the surgeon is not able to take more bone than was planned during the pre-planning stage. So what this technology does is it gives the surgeon so much more information than was previously available to the surgeon to ensure that the knee is well balanced, is well aligned, and is stable, and is in the right position throughout the range of movement. So the big advantage from a surgical perspective is that you're able to be reassured, the surgeon is able to reassure patients that the technical approach was optimized, and then what it does is allows patients to focus on the rehab and the recovery afterwards with full confidence, knowing that the technical approach was optimized. Studies have shown that the procedures has resulted in better accuracy and precision when you compare it with the manual or the conventional way of implanting knee replacements. Early studies have shown in the knee replacement robot-assisted cohort of patients that they do better than manual conventional knee replacements, with this study showing 83% of patients reporting a natural or normal feeling knee at 2 years. When this technology was compared with another system, a computer-navigated system, it had better outcomes. When compared with the conventional knee, Kayani, this author, had shown that there was less pain for patients, quicker recovery, reduced length of hospital stay, and better range of movement after surgery. And again, another study, this is a multi-surgeon study showing that you get good outcomes following robot arm assisted knee replacement. When compared with the standard conventional way of doing knee replacements, the satisfaction levels were much higher with the robot arm assisted procedure. So in summary, what the robot assisted technology does is presents us surgeons with an opportunity to very carefully plan the procedure before the patient enters the operating theater. It allows us to fine-tune the operation. We're able to very precisely and accurately implant the prosthesis that is tailored to that individual patient. And what it means for you as the patient is better outcomes in terms of quicker recovery, quicker return to work, and where it may be the future for knee replacement surgery is that it gives surgeons the confidence to suggest more minimally invasive surgery, such as partial knee replacements. What we know is partial knee replacement is advantageous compared to total knee replacement. We know this from our experience with doing this the conventional way. It is associated with reduced blood loss. Patients recover a lot quicker, and patients are much more satisfied with partial knee replacements. So why not partial knee replacements for every patient, even though the vast or the majority of patients have localized arthritis? The reason for that is that it's difficult for surgeons to consistently perform it well, and this has led to early revisions. With robot-assisted technology, we know that partial knee replacements perform with robot-assisted technology has better outcomes in terms of less pain compared to the conventional way of performing or performing partial knee replacements. It is far more accurate. The majority of patients are able to walk without a walking aid 3 weeks after surgery. 85% of patients return to work 6 weeks after surgery using robot-assisted partial knee replacement. The early outcomes are certainly comparable to the conventional way of doing partial knee replacements. So we have this range of technology, and it's critical that as patients we are assessed expertly, not just by surgeons, but hopefully by a multidisciplinary team. So what I mean by that is your physio and a surgeon in a team that can assess what the best treatment is for you. We're looking very carefully at how these new technologies would work for our patients, and all of us would keep data in relation to how well these joints are doing moving forwards. So just to emphasize that, it's not just a surgery. You've got to work hard yourself following a knee replacement, whether it's partial or total knee replacement. You've got to work well with your colleagues to ensure the best possible outcomes. For me, what the robots assisted technology has done for me is give me a lot of confidence in terms of planning and actually performing the procedure with immediate feedback and flexibility. And I know that my experience so far is that my patients are happier, they have less pain, they recover quicker, but we need to keep following our patients up to confirm the same. So in summary, robot-assisted technology has resulted in improved precision and accuracy of positioning the implant. It allows for a tailor-made surgical plan. There's potential for less invasive surgery. What it means for you as patients is less pain, reduced length of hospital stay, quicker recovery. It's particularly important following knee and partial knee replacements, and increased potential for more normal feeling knee. So thank you very much for your attention, everyone.
Okay, thank you, Winston. We're just going to hand you over now to Professor Fehily. So, Professor, you are live now on the screen. If you could get your desktop ready, and we'll share that after you've done an introduction. Oh, you're on mute as well.
Not anymore.
Nope, that's all good to go.
So, hello everybody. My name's Max Fehily, Professor Max Fehily, and I'm a pure hip surgeon, and I specialize in kind of keyhole surgery where we try and preserve damaged hips, and then the other half of my job is doing robotic hip replacements, basically. So thank you very much, Winston. That was a great talk, actually, and I think a lot of what he covered, particularly with regard to the arthritis side, and also through trying to going after excellence and recovery after surgery, is just as valid for hip replacements as it is for knee replacements. So I'm going to talk a little bit about success of hip replacements and why we've started to go into robotics, what we're trying to achieve, and then a bit of an example of why it's so useful for us as surgeons. And then after me, our third colleague, Adam, is going to talk about some evidence around it and best practice, and also a lot of stuff around the Alex as well. So we're very much presenting this as a team. So I'm just going to load up this presentation, if you bear with me. Just give me a second. Can you see that, Vicky, yet?
Yes. Would you like me to put that live for you?
Yeah, we'll just get started. So, as I said, we're going to talk about Mako robotic hip replacements. So, we're very lucky in the UK. We have a thing called the National Joint Registry, which was essentially founded after problems with older style implants. And essentially, any hip or knee replacement that's done in the UK is put into this, whether it's in the NHS or in the private sector. And the great thing about it is it allows us to monitor how well implants do and how well operations do, and also how well we do as individual surgeons. And I know Adam's going to touch on this a little bit later on. From my point of view, this graph, it looks a bit complicated, but actually what it shows is how long you can expect your hip replacement to last, depending on whether you're male or female and how old you are. And so if you look at the graph on the left-hand side, if you're male and you're under 55, then after 14 years, there's at least a 10% risk that that hip replacement will have failed and you'll have had a revision. Females are slightly worse, I'm afraid. So over the same period of time, they have a 14% risk of failure. And as you go down through the age groups, that risk of failure goes down. And that probably reflects, one, how long you live, but also how active you are. And it's particularly the activity thing that we're now starting to get really interested in and trying to work on improving. So this is just a bit more detail. So if you use a good implant that's put in properly, if you look at the first of the red circles, the top one, at 14 years, you have over a 95% chance that that implant will still be working well, as opposed to a resurfacing or a metal-on-metal hip, which some of you may have heard of, where across the whole range, you have nearly a 15% chance of it failing and needing to be redone. So essentially, it's 3 times more likely to fail. If you look at the younger group, the more active people, the survival of the good implants is still about 95% at 14 years, but the resurfacing drops down to nearly 25% failure rate. And that's why us hip surgeons have moved away from doing metal-on-metal hips. And in fact, while there are still some people having it done, and obviously Andy Murray had it done, within the Northwest, there's nobody doing resurfacings, and I think that's a good thing. But revision isn't really the whole story. So in other words, you can have a hip that hasn't been revised, but it may not allow you to do what you want to do, to be as active as you want to be. And it doesn't tell us whether you're having pain or other kind of issues with it. So it's a very crude measure. So it's much more now about function. You know, people come to all 3 of us wanting to stay active, wanting to play sport. You know, your 40s, 50s, 60s are really important years to get you as fit as you can be for the rest of your life. And that's something we've learned from coronavirus. So here's just a couple of very quick articles that were published. So this one looked at how active people are after their hip replacement. So they followed a small group, but followed them for 2 years. And while all of them returned to some form of activity, there was a general move from doing high impact to low impact. And what wasn't clear was that because they themselves were worried about doing this kind of sport, or was it because the surgeons just didn't have the confidence in the operations they've done to allow them to do what they wanted to do? This was a bigger group of patients, and they looked at multiple papers, so 13 papers in all, and all the patients were keen to get back to what they used to do in the past, but they were still really hesitant to try and increase their activity level. And then finally, this is a small group, so 86 patients, but they followed them for a long time, so it's 10-year follow-up, and nearly 90% remained active. But there was a really obvious decrease in the type of activities they were doing. So they weren't playing high-impact sport, they weren't running, they weren't playing tennis or squash or badminton, and they were restricting themselves to much more low-impact stuff. So how can we make it better? How can we keep people being as active as they want to be? So certainly by getting perfect muscle balance, and Winston alluded to this around the knee, and it's just as valid for the hip, making sure that you recreate the person's normal anatomy. That will allow them to stay highly functioning and allow them to be active and play sport. If you get their leg length perfectly equal between the two sides, they tend to have much less pain around the hip or their back and much better function when they remain active. And then if you can get the implants in a perfect position, they're much less likely to dislocate and they're much less likely to get wear. And we hope that that will give them much longer survival of their implants and so reduce the need for revision in the future. So these are the three things that we're really trying to improve, and that's why we've all gone into robotics. So is there evidence for Mako? Well, there is. There's now about 26 Makos in the UK and probably between 500 and 700 globally. So it's now becoming very widespread with hundreds of thousands of both knee and hip replacements carried out around the world. And these were some very early papers that were published. So this was at the very beginning when they just wanted to show that it was actually safe and reliable. So they compared a group of robotic hips versus standard hip replacements. And on the robotic side, 100% of the cups were put in that perfect position versus only 80% of the normal hip replacements. And that's because essentially when you're doing it without robotics, you're really just eyeballing where you're putting the implants, no matter how experienced you are. This was another study which compared 100 robotic hips versus 100 standard ones. They followed them up for a year. They showed there was no increase in complications, no increase in blood loss, and significantly better what we call patient function scores. So these are the scores which look at how well you're walking, you're running, are you exercising, how comfortable you are afterwards. So these are much better ways of looking at hip replacements than just looking at revision rates. And then the last one, again, 162 patients, all had robotic hip replacements with a minimum of 2-year follow-up. And that's important because you will see a problem before that 2 years if there's going to be one. And they all generally had high patient outcome scores, no leg length issues, no dislocations, and no increased complications. So these three articles all show that it's safe, it's reliable, and actually the patients do significantly better afterwards. So how does it work? Well, essentially, like the knee, you get a preoperative CT scan, which is usually done around 2 weeks before, but we can turn it around a bit earlier. And often there is a difference in leg length between the two sides, and that will tell us exactly what the difference is and exactly what the position of your native hip is. So in this case, this patient was 4 millimeters shorter than compared to the other side, and we can then correct that. Then we work out where exactly we put the cup, what angle we make it, how far into the bone we go, make sure we have enough bone all the way around to make sure that it's really well bonded. And then we can look at these in multiple different ways and spin the implants around and be really precise about where we're putting it. And then once we're happy with the cup, we can work out exactly where to put the stem. And we often use a couple of different stems to make sure that we have the right one for you, for your age, for your activity level. And we can work out where to put it to make sure those leg lengths are perfect and your muscle balance is perfect. And then while we're doing it, we can check to make sure everything is right. And then at the end, when all the bits are in place, we can measure exactly what that leg length is, what the muscle balance is, and we can make any final tweaks we want to at that last minute before we close up and the operation is over. So all the way through, there's absolute precise control of what we're doing, and that's the whole point of robotics. So let's look at a couple of actual patients that we've done. So this is a patient with a very arthritic right hip. It's on the left side of the screen. That's just the way x-rays are taken. She was 5 millimeters short on that side when compared to the other side. And so we were able to take that into account and correct it. And this is the final image after the implants had been done. And we had her perfectly balanced in her leg length and really good muscle balance. The next one is a patient who'd already had a hip replacement. And sometimes you can see really big differences. where she's been operated on elsewhere. There may be a really big leg length difference, either too long or too short. The muscle balance may be wrong. And so we can get them really well balanced between the two sides and make sure that the muscle balance is perfect. And that's what we did in this case, where they were perfectly balanced between the two with not even a millimeter difference. And then finally, I do a lot of complicated hip replacements. And while it's brilliant for normal hips, it's fantastic for the really difficult ones because it really allows you to plan those surgeries. So in this case, this lady had very shallow hips, what we call hip dysplasia. She was very young, and we were doing both sides at the same time, which is something we often do. There was a 3 millimeter difference between the two, but the cup was really abnormal. And so in order to get it perfect, we had to bore in by 11 millimeters, go up 3 millimeters, and go back 3 millimeters. And by doing that, we were able to make sure that it was in a perfect position. And Mako allowed us to put the cup exactly where we had planned, and she did really well. That was her stem plan, and then that was the final implant. So we got perfect balance between the two sides and perfect implant position. And she was home after 4 days after having both of them done. So I'm just going to show you a little video just to give you a bit more information.
My name is Professor Max Fehily, and I'm a consultant orthopedic hip surgeon specializing in robotic hip replacements and keyhole hip surgery. Mako is all about precision. It's about working out what exactly type of implant a patient needs and making sure that it's put in the most perfect way that we possibly can. So historically, a hip replacement has been a really successful procedure, but there's always been risk of complications. And the most obvious ones are changes in leg length, or not getting that soft tissue balance quite right, or the risks of dislocation because the implants have been put in incorrectly. So by using the CT and then the robotic element, you can make sure that you've got the exact fit correct. You can make sure that the cup and the stem is put in perfectly so that the soft tissues are really balanced so they get really good muscle function afterwards. The aim of this is to increase the lifespan of the implant and also improve the recovery of the patient. That should give the patient the confidence to speed up their recovery, to get off their crutches quickly, to get back to exercise, and have the confidence to know that really there's very little limitations in what they can do long term. I've been doing Mako robotic hip replacement since 2018, and so for me, roughly 95% plus are all done robotically. And I do that because I know that the patient will get a better outcome from using that type of technology. Delivering Mako at the Alex for my patients is fantastic because it really builds on the long history that the Alex has had within Greater Manchester. The addition of Mako allows us to add cutting-edge technology on top of that long history of excellent patient care, so that we know that not only will those patients be looked after well, but we're using the best possible technology and implants that can be used.
So Mako is all about precision, and I think it's technically difficult to use, it's complicated, and the kind of surgeons who will use Mako are ones who tend to do a lot of hip or knee replacements, but they tend to be very good surgeons. But I think what we all have in common is that we acknowledge that we're only human, humans can make errors. And the great thing about Mako is it allows you to do exactly what you planned in every single case. So it just gets rid of that human error element of it. And I think certainly for me, it's been a huge game changer, and I'm sure it's the same for the other guys. So thank you very much. And if you have any questions, please don't hesitate to let us know.
Thank you, Professor Fehily. That was brilliant. I'm going to hand you over now to Mr. Hoad-Reddick. So Adam, your camera's going live now. Just to remind everybody, you can ask questions on the Q&A section on the right-hand side, and we'll do our best to answer those as the talks are going on. Mr. Hoad-Reddick, over to you.
Good. Good evening, everybody. Thank you for taking the time to join us in this webinar. This is the first webinar that I've done to patients. We did one to physios and general practitioners yesterday. And it's very good for us to have all been able to share our experiences with you with the Mako robotic system. Thank you very much to the Alexandra Hospital and to Vicky for organising this. And also, I think you've had excellent talks, both from Winston, Kim, and from Max Fehily. And as Max touched upon, really, we have quite a team approach to surgery and evaluation of patients. I think that we all have quite a lot of experience with the Mako between us, and I think it's a useful thing to be able to discuss cases. So we're talking about patient outcomes and the importance of quality. And in terms of the objectives, I think it's very difficult in terms of what quality means, you know, in terms of joint replacement, the patient's perspective. So what you're wanting to know, what's the surgeon's perspective in terms of quality? Where can you look to see what's going on, and also what data is available? So joint replacement is, you know, it's very well established. It's been around for a long time. Hip replacement, classical groin pain. You can see on the image here of a kind of a diagram of what arthritis looks like, and then an arthritic hip on an X-ray. And it takes quite a lot of a team effort in terms of replacing a hip. And it was a pleasure to do the first Mako robotic hip replacements and robotic procedures with the Mako at the Alex yesterday. It's been quite looking forward to it coming, and unfortunately it was a bit delayed because of this coronavirus that you may all have heard of. Here's the team that's involved, and it's all quite subspecialised really in terms of what we're doing. And the aim is to deliver a hip replacement that solves the arthritis and hopefully allows you to get back to enjoying the activities that you want to do, whether that being playing with your grandchildren or doing more increased activities than that. And we'll touch upon what's possible later on in this talk. So from the patient's perspective, I think you want to know what's causing your pain. Where should you go? Who should you see? What are they going to recommend? And do I really need an operation? And then also other things. How good is my surgeon? What could possibly go wrong, and will my surgery be successful? And it's interesting, I don't know if any of you have watched the Andy Murray journey with his hip replacement. He found it very difficult, I've heard, to find out, because tennis players have a ranking system. We don't have that in orthopedics, so it's difficult to know what's happening. So where to start? You know, what is important to you? Ultimately, it's about quality, but what does that mean? Quality in healthcare is about safetyness, effectiveness, professional values, your experience, and quality of life. So quality in healthcare means that we're providing the care that the patient needs when the patient needs it in an affordable, safe, and effective manner. We will all agree that quality is important to everybody, to all patients, but in different ways. And so it depends really what you're looking for in terms of function or abolition of pain. And we need to be able to provide information to you in order to help make those decisions. So first of all, about which hospital would you use? You can look at the CQC visit reports. You can look at the media, and we'll touch upon what the Telegraph said about the Alexandra Hospital, little detail in a while. We could talk about the surgeon's data, and you may have heard of FIN, which is the private hospital's data, but the data that you can get from that is very limited at the moment. You can look at number of cases. You can look, and increasingly we're seeing this, and all three, Winston, Max and myself, have patients coming from far and wide now who are choosing to have a robotic joint replacement. And you can also look at National Joint Register, which gives hospital data and also individual surgeon data, and we'll touch on that in a little while as well. So in terms of the Telegraph, I'm quite proud of this slide. The Telegraph published the worst 10 and also the top 7 hospitals for joint replacement surgery. And the Alexandra Hospital was in the top 7 hospitals for risk of failure of your hip replacement once it had been done. And it was the only private hospital on that list. And it was amongst some other really good specialist centres. So I think, you know, all the surgeons working there and all the staff at the Alexandra Hospital are very proud of that data. So the Alexandra Hospital, as I've said, here's a picture of it if you don't know what it's like. It's listed in the best hospitals for joint replacement surgery according to National Joint Registry data, and it was the only private hospital to feature within the leading UK hospitals for hip replacement surgery. What makes it special? Well, it's the largest private hospital outside London. Do I have confidence in taking my patients there? Of course I do, because otherwise I wouldn't. Why do I have that confidence? Well, it's got on-call consultants in intensive care medicine, radiology and general surgery. It's got a fully staffed intensive care and high dependency unit to a level where they will be having patients who are ventilated, having had open heart surgery. That also means that there's a resident registrar in intensive care present 24 hours a day. So if there's an emergency, there's very good cover. And then also it does a very large volume in terms of activity. So they do a lot of orthopedic surgeon there, which means really at the bottom line, there's loads of good kit. I did have on there that they had availability of lots of different systems and equipments, but my wife thought I'd be better to say it had loads of good kit, which is really where we are. And that, of course, now includes the Mako robot, and we're all really pleased that we can offer that. Which surgeon? So what can you look at? You can look at what hospital base they have, what robotic access they have. You can, of course, look at their websites for individual surgeons, but I would suggest to you that might be biased. You can look at National Joint Registry data. You can look at number of cases. You can look at complication rates and death rates for surgeons, and also then their risk of revision surgery in the future. So what about me? I, like the other two surgeons who've spoken tonight, so Winston and Max, are in full-time orthopedic practice with busy joint replacement practice. And my patients account for about 20% of the total number of hip replacements performed at the Alexandra Hospital. Of course, we can all put up our I want great care reviews, but again, that comes down to, is that selective, and it's something really for websites. So yes, we can put these I want great care reviews on, and you know, we've all got these here. But you know, what can we do from a surgeon perspective? I ask myself, how can I offer my patients the best joint replacement possible? Does the robot help us to achieve a better implant position? How good is my implant? Which hospital is the best? And how can I minimize those risks? And we've heard great talks again from Max and Winston about the positioning of implants and how that can be exactly right. It may only take a trained eye for me to tell you that on the left side, the cup isn't fully anteverted, so isn't facing forwards quite enough. In most patients, that won't matter, but in some patients it will. Maybe that's about the feel of the joint or an increased risk of dislocation. But undoubtedly, we can see better positioning of joint replacements and better equalization of leg length and offset through use of these fantastic technologies that you've already seen about. So with meticulous preoperative planning and execution to within a millimetre or a degree of where you want to put it, undoubtedly means that we can achieve very good positioning of implants. The other question is, what implants should we be using? And that's a very difficult and somewhat vexed question. In joint replacement, as Max alluded to, we're not really doing any metal on metal hip replacement. So on the left, you can see a hip resurfacing. On the right, you can see a larger diameter ceramic on ceramic uncemented hip replacement. And you can look at these implant choices in great detail, so cemented versus uncemented, and bearing surface choices, along with bigger head sizes, which reduce the risks of dislocation. And you can see here again on this diagram a resurfacing, a short-stemmed hip replacement with ceramic bearings, and then a metal-on-metal hip replacement, which we wouldn't use. And I mean, again, as has been said, in the northwest of England, nobody's doing resurfacing or metal-on-metal hip replacements anymore. To talk about the ODEP rating, that's an assessment of the likelihood of requirement of revision for that implant. And we all should really be using something that has a 10A ODEP rating, which means that it's been followed up for 10 years and has a certain success rate and a low requirement for revision surgery. Again, if we look at that in real terms, failure rates for hip replacements. Now this graph, although it looks complicated, the yellow line shows by 15 years there's a nearly 25% revision rate for a metal-on-metal hip replacement, which is why we've stopped doing them. You can see for all the other bearing options, so metal on plastic, ceramic on plastic and ceramic on ceramic, the revision rates are around 5% by 15 years. So very good results and very good in comparison to what we had before. Why do hips fail? So the reasons for hip replacement failure, they can be many things. So if a hip gets infected, it may need to be changed. If it dislocates, revision is required. And dislocations now become the most common requirement for revision of hip replacements, for example, in female patients over the age of 70. So loosening and failure of bony ingrowth can be a technical problem, namely not putting in a big enough implant, and can also happen in the long term in association with wear. Of course, you can fall or you can have a fracture around the hip replacement, which may mean that it fails and needs to be redone. We've already seen this graph about failure across the age group. So the younger you are and the more active you are when you have your first hip replacement, the more chance it is going to fail earlier. A bit like the clutch in your car. If you drive it hard, it's going to fail earlier. It's the same as any other mechanical bearing. What about the results? Head burying is not an option when it comes to looking at the results of joint replacement surgery. So we've been touched upon again, the National Joint Registry, in terms of monitoring and looking both at surgeons and at implants. So what is it? It's the largest and most comprehensive national audit of joint replacement surgery in the world. Now, there are over 1 million hip and over 1 million knee replacements in that, and it's led to fantastic understanding of what's happening. We all have to put our data into it, and the aim is to improve clinical outcomes and drive future development for the benefits of patients. So what use is it? We can evaluate the performance of specific implants and see where they should be improved or where they should be discontinued. And we can also look at and assess a surgeon-specific outcome compared with that of their peers and the national average. And that's quite important. So if a surgeon is beginning to see higher rates of revision surgery, the National Joint Registry will write to the hospital in which they work and ask why that might be happening. So how does that work in detail? Your National Joint Registry data on an individual surgeon basis covers both your hip and knee replacement practice and also the number of primary and revision surgeries that you've done. And so you can look at the number of primary joint replacements, so around 100 a year or 100 a year. And from that, they can give you this data. And so this gives you the data as to whether your range of revision surgery is better than expected or worse than expected. And you want these little red triangles ideally to be on the right side of average. And so I think that it's important. All your surgeons will have this data. And if you don't know what's happening and you want to, I would ask them what their data is like. And that gives you a good reference point in terms of the number of cases they do and whether they're achieving good success rates in terms of failure of requirement for revision surgery in the future. So what comes next? You've selected your hospital and you've selected your surgeon and your operation's been performed and your joint's been replaced. So then comes to recovery, so time for rehabilitation and physiotherapy. It's outside the scope of this talk to discuss in detail the requirements for physiotherapy, but we're all seeing that patients who have Mako robotic hip and knee replacements are recovering more quickly and have less pain. So the aim is for resolution of pain and resumption of activity and restoration of quality of life. And I thought I'd share with you a picture of 4 of my patients who've had hip replacements. The photo top left is of a young lady. She was 15 when she had both her hips replaced, and she's now back competitively riding a horse, which is fantastic. Top right, this chap's finishing his 8th marathon in this picture with a hip replacement in situ, and it does worry me what some patients get up to with their hip replacements. The chap in the yellow ski trousers had both his hip replacements, and that's him after he's had those done, and he's fantastically active. And then bottom right, the lady with the guide dog, she competes for the UK in both football and tennis as partially sighted. And so hip replacements these days, particularly with modern technology implants, is not a barrier to normal activity. I'd be happy to take any questions now. Thank you.
Okay, we have a question. It's relating to knee replacement. So I'm not. So hi, could you let me know, is surgery advised and what the prognosis is for total knee replacement or a partial knee replacement for a person in their 50s suffering with severe OS, OP, bone on bone and complete damage of ACL, PCL, MCL, LCL and meniscus? Also, the advantage of using Mako in this scenario. Many thanks and thank you for this event.
Vicky, do you want me to take that, or is Winston on and he can take it? I'm happy to, or?
Winston's still on, but Winston, you're on mute if you want to.
Yeah, sure.
I'm going to send you a camera live. Okay, Winston, you're on.
All right. Thank you for this question. So first thing to say is that surgery is, talking about total knee replacement, is a quality of life operation. So whether or not you decide to have surgery is very much dependent on your function and your quality of life, and assuming that you're very troubled by knee replacement and you've had a period of non-operative treatment that has failed, then knee replacement is a very successful operation. It's got very good results if you're prepared to put in the rehab and be prepared before surgery. So what I would say is that in relation to somebody in your 50s suffering with severe arthritis, and it seems like you have, because you're bone-on-bone knee arthritis, that you'll do well. Chances are you do very well from a knee replacement. So the question is why Mako? I think the first thing to say is that you have the reassurance from a patient's perspective that you will have a surgeon that will be able to perform a knee replacement that is tailored, that has a surgical plan that's tailored to your anatomy. So all of us have different anatomies in terms of the size and shape and alignment of our joints. And so what this does is it has a tailor-made, Mako has the ability to tailor-made the implant positioning for you as an individual patient. So what it does, it gives the surgeon so much more information to be able to balance the knee and have real-time information during surgery to know that the knee the knee is technically performed according to what is optimal for your anatomy. So what it does is that, of course, after surgery, you don't have to worry that the technical approach to surgery was faulty in any way. It's optimized, and then you can then focus on your recovery. And what's reassuring for patients, and I see in my practice, is that that I have seen is that Mako has Mako knee replacements and hip replacements as well is associated with reduced pain after knee replacement. Patients recover quicker. They're far happier with the knee, and I'm confident and that the studies in the medium term will show that there is an advantage in terms of a greater potential for a normal feeling knee in patients who have had this technology. So I think that's the big advantage of using robot-assisted technology, using Mako robot knee replacement. Vicky, I'm afraid we can't really, we don't even know, we can't really tell in terms of the feedback, isn't it? Because we can't.
Yeah, I know, you can't hear it. We've had some great feedback.
Helps anyway.
A few people messaging to say the event's great. We've recorded the feedback, the session, so because some people have had problems with Wi-Fi dipping in, dipping out. Some people missed the start, so we'll make the recording available on our social media channels. There's another question that's come in about a personal case, which Professor Fehily's replied to. Thank you very much for that, Professor Fehily. We've got no more outstanding questions, so I just wanted to say a massive thank you to all the speakers today. It's been a really well-received event and well-attended. Thank you very much to everyone involved. Thank you for everybody who's come online to take advantage of the session that the consultants have put on this evening. Do any of our consultants have anything else they want to add?
Yeah, Vicky, it was just about that question. I know it hasn't gone public, but essentially it was a patient who had a problem elsewhere with a joint replacement. And I suppose the thing that really jumped out to me was, if any of us, certainly the three of us, have you can have problems with surgeries, but you always make sure you look after patients long term to make sure that they do well in the end. And I think all of us who are very experienced surgeons, if we had a difficulty or a problem that we couldn't solve on our own, we would always get one of our colleagues involved to help. And I think that's the sign of a good surgeon who cares about their patients, rather than somebody who would just abandon a patient if there was a complication or a difficulty. So.
And we've just had another message just to say, Max fitted my new hip at the end of February, 7 months later, I'm pain free, have perfect leg length, was 10 millimeters shorter, back cycling 150 miles a week and doing 10-mile walks. I was in hospital for 3 nights. The care and advice I received was excellent. So thank you very much for that feedback. That's really good to hear. Okay, so thank you for that, Professor Fehily, and thank you, Mr. Kim, Mr. Hoad-Reddick. It's been a great evening. I hope everybody that's attending has enjoyed it. We will make the recording live on our social media channels, so those who didn't get to attend or only got to see part of it will be able to catch up. Thank you very much to everybody, and I wish you all a good evening.
Thank you very much.
Bye.